So welcome to our September 26th, 2025 Project Echo Dementia session. And I see a lot of familiar faces here, so you are quite well versed with our our program, but lovely to see you and always appreciate you being here. We will do just some basic housekeeping, then we will move into our didactic. We're incredibly fortunate to have Rachel Westman with us today, who's also prepared some case vignettes, as we do not have a formal case. So a couple reminders, if you can rename yourself. I see a couple of unclear, or at least one unclear name. That would be great, just so we can keep track of attendance for CME and other purposes. If you can't, that's understandable too. Looks like everybody's muted. We have practiced that, and I will try to practice saying my name also. So I'm Chris Rhodes. I'm one of the leads for this. If you're able to turn your video on, always lovely to see your faces. If you can't, that's understandable too. And if there's more than one of you in the room, great to have all that info so we can keep track of who's here. So about CME, if you are affiliated with the University of Washington, faculty, staff, student, here's the process to obtain CME. We'll put this up at the end also, and this is good for about an hour before and after each session. And that, again, is free. Due to our generous funding from the state of Washington, we are able to provide free CME. We will also keep track for everybody else just through our usual protocol. And thank you to Sarah, who's filling in for Sammy, to do that. She'll reach out to you if we need any more info. We have accreditation through the UW. To provide that CME. We have no disclosures to reveal here, neither the planner nor our presenter. Just to remind you about a few other things, I had the good fortune of doing the didactic for the HIV echo session a little while ago, and really love the idea of kind of cross-pollinating. We're going to have someone from their team talk about HIV-related dementia, HIV and aging, later on. So there's lots of great echo programs out there. We're one of many. So there's echo geriatrics. You can see all the ones here too, the TBI groups. Lots and lots of resources to enhance your clinical practice. In addition to some consultation lines, which we have those for you as well. These are all in the slides for your future reference too. And then, of course, repositories of information through the Grand Rounds archives, neurology, psychiatry, cases. We have had some fantastic cases. Every case has been fantastic, and we always learn so much. So I would encourage you, if you have a case, no case is too simple, no case is too complex, please reach out to Sarah. We'd be happy to make the lift as light as possible to present that case. Of course, also always welcome just to bring up clinically relevant issues. It doesn't have to be a formal case presentation. There's always room for that here. We've learned so much from it. When we do discuss cases, doing our best to protect PHI, we have gone back and edited things out in the past, but better to do so preventatively and proactively. All of our information is on our website, which is growing by the week, it feels like. And we have turned this program into what it is based on your feedback over time. So appreciate the input on that 1-minute post-session survey. And I know our presenters always appreciate that too. Everyone's here trying to do the best they can to make this the best possible. So your feedback, unvarnished feedback, is welcome. Here's our Echo team. We're a little light today. We're missing a few folks for a couple of reasons. Small but mighty. Here's all of you out around our great state and other environs. I'll spare you all the numbers, but we are continuing to grow in terms of our connectivity and our folks who are involved. I'll share also that when we first envisioned this program, we wrestled with whether to have a cohort that would go through kind of the 10 basics, graduate out of that, and then do a new cohort. And we very intentionally decided to make it more of a community model. And it's so nice to see some folks here who haven't maybe been here for a little while coming back after months or even a year or so. So you are always welcome. And there's it's so wonderful to have this network of providers around our state who are kind of doing this work together. So we've learned a ton from you as well. And with that, it is my pleasure and honor to introduce our presenter today, who will cover both some didactic information and some case vignettes. And I was just sharing with her, I'm coming from a program that we offer here at Memory and Brain Wellness that includes a support group component. And a couple of participants were puzzled over what to do about their 23andMe results. So I'm looking forward to getting some guidance about how to talk about that with folks, as I'm sure it comes up for us all. So my pleasure to introduce Rachel Westman, who is with the Genetic Support Foundation. She is located in Idaho, and they provide resources and services for a variety of clinics, including through the Providence system. So I will stop sharing and turn it over to you, Rachel. Thank you so much for being here.
Great, thank you. My slides here. All right. Great. So I'm Rachel Westman, genetic counselor. I have, my background in terms of dementia and kind of neurological conditions is that I've always practiced within pediatric and adult genetics, and really probably for most of that time have done genetic counseling within this realm at different capacities and stuff, but especially in the last probably 7-8 years has been a big role for me. I do not have any financial disclosures to report. And really so through this kind of presentation, just wanted to be able to have a chance to just talk through kind of the different, from a genetic testing, genetic counselor perspective, different things that we think about in terms of the genetic causes of dementia and how we approach genetic testing in the different categories of it that we look at, and also kind of the conversations that through your clinics you may be having with patients. So being able to kind of identify what those different genetic risk factors might be, when to consider testing, and just a lot of the different things that really are part of it and the impact that this can have on people and their families. So why genetic testing and why is that relevant? One of the kind of primary aspects, and kind of I would say just what we were just saying there in terms of the APOE, is that direct consumer testing continues to grow. There's definitely been an ebb and flow over time in terms of how people have accessed it, how many people are accessing it. We're definitely in a swing of seeing a lot of people really using it or doing it and then getting surprise results from it. And that's something where in the primary care setting, you're really gonna see that a lot more often, or have probably more of those conversations where someone's done this sort of testing, they don't know what it means, and now they're coming to you asking for help or support around that piece. So there's really expanded access. Because of that, there's also expansion in terms of just the general kind of clinical genetic testing that we're doing. It's really changed in the last 10 years. And I would say even in the last 5 years has changed quite a bit in terms of how we're approaching that piece of it. And so it's much more part of the conversation when we're talking about dementia. But with all of that, there's often limited guidance. So patients might be able to access this, but they're not being given very much information through that process, particularly when they're doing direct-to-consumer testing. And then other aspects is kind of things that have been in more of the mainstream media is kind of the new and different treatments that have been starting to become available, in the fact that genetic status can impact some of that and what you can access for it. So the two types of kind of genetic categories or contributions that we think about with dementia are, we have kind of our Mendelian or single gene causes of dementia. And so that's where you've got this one gene, a variation in that gene, and we know that that's high likelihood that it's going to cause dementia, so an almost certainty. So really more of a predictive, deterministic part of it. Most of the time, these are ones where these variations are inherited in a dominant pattern. So often we're seeing a family history of it, or a family history of something that might be related to it. Now, there are a handful of them that are inherited in other patterns like X-linked or recessive, but most of the time it's going to be a dominant inheritance that we're seeing in comparison to kind of this more complex kind of risk factor, genetic risk factor category. And so that's the prime example of this is ApoE, where you can have these genetic variations, but they're not solely causative. It's really kind of this combination. And within dementia, we know that genetics plays a role in it. For most people, it really is these risk factors and this combination of both genetic and non-genetic factors that are playing a role for individuals and kind of what puts them close or over that threshold for developing disease. But it's just not as straightforward, and the testing and how we interpret it is just not as different between the two categories. So start with kind of the ApoE kind of example of testing and what it means for individuals and families and the testing and things to consider with it. With ApoE, just some background regarding the gene is that I don't put it here and I'm not going to talk too much about it. Well, we talk about it the most in terms of it increasing the risk for dementia. We also know that it impacts cardiovascular health too. So it's more than just this one question that has to be considered. But for this part, I'm just really going to talk about more of the dementia piece of it. We know we all have 2 copies of this gene, and people can have different variations in this gene. The most common ones that we talk about are the E2, 3, and 4 variations in the gene. Most people are going to have the E3 version, and that's just when people have 2 copies of the E3, they are really just kind of at general population risk in terms of kind of that baseline risk that we're talking about for dementia. And the E4 is the one that is increasing the risk. So for if you have 1 copy, it increases. If you have 2 copies, it increases even more. The E2 one is important in that it can actually reduce that risk some. And again, these variations can have different impact when we talk about other health problems like cardiovascular piece of it. The testing and the counseling is kind of is something that really has increased quite a bit in the last few years, particularly because of some of the emerging kind of therapies and applications, and that ApoE is a big part of that conversation now for some patients who are affected. The ApoE is included on a lot of the direct-to-consumer health panels. Some people know that, some people don't know that until they do the testing. The current guidelines really by multiple societies, both within genetics and from other organizations, are to not do ApoE testing in unaffected individuals, primarily because we just don't have a whole lot that we're doing differently for people. So there's limited clinical utility for it in someone who's unaffected. And at this point, we're not really making significant changes for them or for the family. Now, it is absolutely something that's a part of the conversation for people who are in early stages with dementia because of the impact with some of the therapies, but those are really kind of different categories, different conversations that are happening for people. But one of the most important parts when talking about ApoE and when this comes up in conversation is that it's a genetic risk, which means it does not mean that people are absolutely going to develop disease. While it increases the risk, it does not mean that they for sure at some point will have it. And that can be a hard concept, I think, for some people to really kind of wrap their heads around, where a lot of the times they're getting these results with no information other than just saying they're at an increased risk now for it. And they're not really getting the balance of the conversation and being able to see both sides of it. And I think that's where really, where as providers, is an important role that we play in terms of having that conversation. Well, yes, maybe it says you have, you know, 25% or 30% increase or upwards of a 70% increased risk. There's still that, potentially 30 to 50, 60% chance that you're not going to develop disease just based on this one risk factor. And we know that within dementia, there are so many other genetic and non-genetic factors that play a role. Some of those, particularly in the non-genetic side, that patients can really focus on and be able to say, okay, what are things I can modify? What are things I can do to help myself? And so it really is helping frame that conversation for them, and trying to help just really balance that communication for them. Then from there, then we've got monogenic or kind of single gene causes of dementia. And we have definitely grown quite a bit over time in terms of what we think about and what conditions we're looking at. So with Alzheimer's disease, that's definitely the one that gets talked about the most. And we know that there's these 3 genes that can cause early onset dementia. In the spectrum and kind of the whole scope of Alzheimer's and in dementia, we know that these 3 genes really only account for a few percent of the cause of dementia, of Alzheimer's. And so while there's a lot of focus on these 3 genes and the specific cause, and many patients I see come in and are very concerned about the potential that they could have one of these 3 genes, or one of these 3 genes is in their family, it's important to look at the broader spectrum of what we can see. Other types of dementia, it can look a little bit different. So frontotemporal dementia, for instance, there's dozens of genes that have been identified at this point. These couple of genes I list here are some of the more common ones in terms of that make up a larger proportion of that genetic. Frontotemporal dementia is very different than Alzheimer's, where particularly if we're seeing a family history of frontotemporal dementia, majority of them are actually, in a good significant proportion of them, are going to have an identifiable genetic variation, particularly if you're seeing frontotemporal dementia and ALS or motor neuron disease within that family. And even those who look like they're sporadic or isolated, about 5 to 10% of those ones are actually going to have a genetic cause that can be identified. And there's definitely some differences in terms of how we approach some of the testing because of that. Vascular dementia, it's another common kind of type of dementia that we see. This one is one where it's most often sporadic. We don't know, while genetics absolutely is playing a role, it's not necessarily an inherited single gene cause, but we know there are a handful of genes that we definitely can see. And so it's important to consider some of those non-neurological symptoms or non-dementia type symptoms too, and whether there could be more to the story for these individuals. And then we have other just types of dementia, neurological neurodegenerative disorders. So like Huntington's disease, prion disease, Lewy body disorders or Parkinson's, genetics absent for, Huntington's disease. We know you have to have a genetic variation for that. Compared to some of these other ones like Lewy body, we're starting to understand more and more about how genetic risk factors really play a role for it. So when do we consider genetic testing? And I'll kind of talk through things that I look at when I meet with a family or meet with an individual, but there's definitely no hard rule here in terms of there's a lot of subjectivity, and a lot of it's based on the conversation you're having with a family or with an individual. But flags that we look for are age of onset. Earlier ages of onset are more likely to be some genetic cause in the sense of a single gene cause that we can see. And so the younger we get, the more likely it is that we're going to potentially identify and something there. Family history. So when we're seeing multiple people affected, when we're seeing multiple generations affected, that absolutely increases the likelihood that there's a genetic single gene cause. That's identifiable there. But it's important to look at some of these numbers I've listed in that it's not an absolute. So just because we're seeing these, it might look very suspicious and like there's gotta be a genetic cause. Genetic testing is not identifying it all of the time for these individuals. Other ones are just phenotypic clues. So we know, like I mentioned, if someone has FTD and ALS, there's a much higher potential that there's a genetic cause that we can identify with testing. Other reasons that we can look at doing testing is that while the diagnosis and differentiation between the different types of dementia has absolutely improved over time, there are still those cases that overlap with each other where we're just not overly sure as to the specific type of dementia or what was the primary there and kind of primary cause for what's going on. And so sometimes the genetic testing can help with some of that clarification and really sorting that out for individuals and for families. And then the big thing is in more recent years, which has really changed the conversation around genetic testing, is the development of some of the targeted therapies and new treatments that are coming out. So you know, 10 years ago, I had very different conversations with people about how we approach testing compared to how we do it now, because for some indications, like FTD, for instance, we didn't necessarily have something specific that we were targeting. FTD now, because of some of the gene therapies and target treatments, it's recommended really that it be considered for everybody. Because if they potentially have, a GRN gene, they qualify for this new treatment that's out there. Huntington's is a great example, and I think yesterday, day before, they just announced kind of preliminary results from a clinical trial in terms of gene therapy that is looking to be successful. So there's a lot of things happening within this space that's really changing the conversation. And so that's really why I talk about, well, these are flags and things to consider. That last one in terms of the development of these different treatments and therapies are really changing kind of who and maybe when we're considering testing for people because of the potential impact for them. In terms of the different types of genetic testing, this is very kind of basic example of just kind of demonstrating the different levels of testing that we can do. With genetic testing, you can go anywhere from more specific, more targeted testing, where that would be things like Huntington's disease. We have a specific gene, specific type of genetic variation we're looking for, and that's what we're ordering. So we're looking at one specific thing, or kind of in between that specific and targeted panels, early onset Alzheimer's. We might just be ordering those 3 genes and looking at those 3 genes because of the presentation within the family. Or we might be doing a broader dementia-based panel where it includes all those kind of different genes that are been more well described or known in terms of the different types of dementia, particularly with Alzheimer's and frontotemporal dementia, and looking at all of those together as a part of it. Those are the most common ones that I'm ordering, and I think that most people in the literature, you're going to see and have been seeing a lot more people and papers talking about exome and genome sequencing. So it's important to talk about those. Exome is where we're just looking at a few % of the whole genome, but it's the part of our genetic material that really provides the instructions for the proteins. So it's where we think majority of genetic conditions are found in terms of the genetic variations. Genome sequencing, we're technically looking at all of it, but there's still limitations to it. It's not perfect, and there's only a handful of labs at this point that are clinically offering it. One of the biggest difference is that genome sequencing can sometimes identify some of those repeat expansions. where exome and some of the targeted panels really cannot do that. So there are limitations there. But genome sequencing, dependent on the lab, determines which repeat expansions can be identified. So you still maybe have to order more targeted testing for somebody. So how do we kind of choose what we're going to order for a patient? Particularly with the more testing we've been doing, the more we've definitely recognized just the heterogeneity of this, and that the different genes that we historically have always said must cause a specific presentation, there may be some variability there, both in terms of how they present and ages of onset. So I have absolutely had both Alzheimer's and frontotemporal patients or families where, and same with Huntington's actually too, where no one in the family had presented until their 70s, but there was a genetic cause that we identified, and that we did testing more because of the number of people that were being diagnosed with it within the family. The preferred method is definitely doing the panels at this point. A lot of the research literature is really focused on doing exome or genome sequencing. And in a moment, I'll definitely touch base on the challenges of that aspect of it and some of those recommendations that are starting to get put out there in terms of considering that type of testing. But definitely technical limitation. If I'm looking at a family and I'm very concerned about the fact of one of the genes or conditions where it's a different type of genetic variation, I have to make sure that that's included and that we can assess for that as a part of it. So some of the challenges, the number one challenge, genetic testing for dementia is often not a covered service. Many insurance plans do not indicate that they will not cover this genetic testing. That, or if they do, it's it can be variable as to how much of it they're going to cover. And so that really can impact how we choose what testing. So most of the time I'm not looking at exome or genome for people because I know that's not going to get covered for them. And so that's a huge part of the conversation with people. Even for people who are affected, it's often not going to get covered. Sometimes we can get it through, just particularly we can make the argument, particularly for the ones like frontotemporal dementia, that it's going to potentially impact. There are also some more sponsored testing programs that have become available to try and help meet this need and help get access for people, but still a major struggle. So there's still an aspect of many people have to pay for this testing out of pocket. The results are not just a yes or a no. So many of the people I talk with, many of the families think that we're going to do testing and either I'm going to tell them, yep, we've identified something, or nope, you're good to go. But there's absolutely some level of uncertainty that comes with any genetic test. It's not always just an abnormal result or a negative result. There's different levels of and types of results that we can see. So like a variant of uncertain significance where I can't really give a clear answer in that, or some of these reduced penetrance variants that we get where we know for some that it increases the potential, but it's not a guarantee for them to develop disease. And then there's absolute variable expression can prove difficult or cause difficulties with this. So like I mentioned before, I've had a handful of families where nobody in the family presented till their 70s. If you look at kind of what's recommended, it's not something that you would typically think about doing testing for. But I have in some of those families identified as something. And then the aspect of low detection rates, particularly when we're talking about things like Alzheimer's disease and the testing there. And as a genetic counselor, I definitely want to focus on some of the counseling and other kind of considerations that are really important within this realm in talking about genetic testing for dementia. And then, I'm definitely gonna be an advocate of saying genetic counseling is a crucial part of this process, whether it's by a genetic counselor or just a provider that's involved in the care of the individual, having these conversations and really sorting through all of these different things are so important because it's more than just understanding the genes that are causing it and the treatments that people may qualify. There's so many other impacts, and really can profoundly impact patients and their families and the life decisions that they are making. Because of that, the model that I follow is very similar to how many within this space work too, and that we do a multi-step process as a part of it, really emphasizing that pre-test counseling, really doing kind of an intake with them, then having a formal conversation, taking time to really sort out all the different risks and the benefits and limitations regarding it. That includes, the impact it has for that individual, impact it has for their family, making sure they understand all of that information. A big part of it I mentioned here is including insurance risks. Um, for every patient I meet with, I talk to about this, I have a conversation about how this type of information, including things like potentially ApoE, but also these single gene causes, can have an impact on a kind of financial insurance status. While we have laws in place through the Affordable Care Act, through GINA, that help provide protections for patients, that's more around health insurance, but there are loopholes to those laws and it doesn't protect everything. And so it's something that has to be considered when having these conversations and looking at this testing. And then uh, post-test counseling. So if somebody does testing, it's important to really have a good follow-up plan, to not just have them get these results and not really be able to have a conversation. It's really important that they talk with somebody to navigate what that means for them, what it means for their family, what are the next steps going to look like, who are we going to connect them with, and just overall follow-up long-term plans. And throughout this, really providing support because it is can cause really significant changes and dynamic shifts for an individual. And some of what I've talked about is kind of this general utility. So part of the counseling is absolutely talking through all of this information, talking through what the role of the genetic testing is and why we might do it. And while absolutely talking about the diagnostic piece, also talking about what it can do in terms of information long term, but balancing all of this information and what it means for an individual with the role of that I play is to help people have this information to support them in whatever decision they make through this process, whether they do testing or don't do testing. But I want them to know all of this information. I want them to have this and have a chance to really think through the overall impact that it may have for themselves and their families. Another part of this is understanding why people are making the decision to do testing or to not do testing. What I don't include on here with some of this is, I would say a primary reason I have people who hold on doing testing is the insurance piece. People are very concerned about privacy and about insurance. And I would love to say that we're in a better place than we were, 20 years ago, but it's still a very difficult spot that people are in trying to make these sort of decisions. And that really leads into the aspect of people make these decisions more based on their own values for themselves, for their families over the facts. They're looking at the whole picture. They're looking at the impact that this is going to have, what decisions they're going to make for their lives, whether they're going to keep working in the job that they're going to be in, whether they're going to start a family or not. So there's just a lot to consider with this and the impact for those individuals. And for many people who are affected or in early stages or caregivers, so I often meet with husbands or wives or partners of people who are affected where they're really doing this for their children because they want to be able to give their children this information to have. So there's less often do I hear in those situations people doing it for themselves. They're really wanting to look at the bigger picture. Kind of risks or challenges to this conversation is that this process can cause a lot of distress for some people learning this information, both positive and negative. So, understandably, people who get unexpected positive results or expected positive results, it can have a huge impact on them. And so it's really important that those are addressed and that we get the right services and support for those individuals. And so as a joint counselor, I'm very reliant on my conversations and relationships with the other providers I work with. So whether it's neurologists, primary care providers, other people involved in their care, I'm very reliant on getting help to help support patients to address some of these concerns and challenges. In case of unexpected direct-to-consumer results, those can cause pretty high anxiety for people of they get this unexpected result that tells them they're at much higher risk for Alzheimer's disease or for dementia. They've not been given any information about it other than just being told on a piece of paper or on their computer screen that there's this high risk. And it can understand why people can become very anxious around that in terms of what that means if they're not given the right information around it. Other things that we have to kind of think through are the family conflicts and family dynamics. Everyone in a family may approach this differently. Everyone may have different coping strategies for how they approach this, whether they want to know this information or not. Not uncommon for me to have a family where one person wants to go down and the pathway of knowing everything, doing everything, while others in a family may not. I will have situations where we know that there's a genetic variation within the family that's causing dementia or some other neurodegenerative disorder like Huntington's. A parent doesn't want to know their status, but the child does want to know, an adult child wants to know. And so we have to have really in-depth conversations with those individuals and those families about what that means for them. And that is something particularly, I think, in the primary care setting that you're going to see some of those dynamics more often than maybe than I may, where I'm doing more of these snapshot conversations with people. And then uncertainty too. I think that the variants of uncertain significance can be really hard for some people, particularly when they're trying to make some of these life decisions in what the future looks like for them. Some other kind of just general considerations as a part of this kind of within the primary care is, when making these referrals or considering testing like this, who is it that's making the decision? Who is the one that needs to give the informed consent? Because it may not always be the person who's affected, who's the proband or patient. It may be a caregiver, but are they doing it in the best interest of that individual and for the family? There's kind of this delicate line with some families and individuals about confidentiality and duty to inform, and whether it's that conversation of letting other family members know about a diagnosis or letting a workplace know. It's a hard balance, I think, and not unique to this area, but absolutely comes up for people. The insurance risk that I talked about, and it's important to consider that in terms of how you document and how that's noted within a patient's chart for them. I'm always going to advocate for referring on for more detailed conversations from the primary care space. I know within primary care, you have more and more pressure to get through so much in such little time with patients. And that's where definitely genetic counselors and other specialists can be there to help support through the process. And then particularly around the APOE piece, addressing some of the stigma in that and balancing out that conversation for people, and that there's definitely a lot of misinformation that's out there in this area. And then from the predictive side, particularly for people who you may have come to that says, my mom, whoever within my family had dementia or Alzheimer's, I really want to do testing, things that are important to consider. We really advocate for not testing minors for these conditions, unless there's very specific questions or concerns that are going on for that individual. Um, and this is the case really somewhat sometimes for those who are affected, but particularly for those who are doing predictive testing, the readiness for it. It's a component of what I do in my sessions, too, with patients of really trying to get a sense of, are we in a space, are they in a space that they have the support that they need, that they're ready for this type of information? And so that's a big part of the conversation. And then with that too, having the conversation about the impact, not just for themselves, but also the family in terms of um, or support people. Doesn't necessarily have to be family, but who this may impact. And then long-term follow-up planning. From the genetic counseling side, I often see these people, I go through this process with them, and then I'm giving them back to primary care or to neurology. And they're definitely, that long-term follow-up is so important for these individuals and these families and helping make sure that they're getting connected with the right resources. I put this slide in here kind of at the end because I want to recognize the limitations for accessing genetics in the region. So these stars are just an example of the major medical genetic clinics within the region to demonstrate how little access some areas of our region have to genetics. And in terms of the stars on this map, not all of these stars will see patients for this and for dementia or neurodegenerative disorder. So I really would say it's even more limited than what this map shows. So I absolutely recognize that. And so that's why I put this here of there are a lot of really good resources that are out there. So both through the genetics clinics in the area, but then also through a lot of the national organizations and foundations for these different conditions. And I can go through some cases. I know we didn't have a specific case, but I can kind of start going through and then happy to also take questions in terms of what makes sense for a time too.
Yeah, Rachel, thank you so much. That was wonderfully comprehensive and pragmatic at the same time. Yeah, I'm wondering if questions or comments from our community?
I have a question. So I'm actually seeing a patient on Monday who's 25 years old and did 23andMe and is APOE4 homozygote, is understandably concerned, and she has hyperlipidemia, which is unsurprising. Um, and my question to you is, would it be worth, since she's already had the APOE testing, repeating it with like LabCorp just to confirm it's not a false positive? And then also, like, would it be worth testing for like LP little a? And because I understand that, the management doesn't necessarily change, but and of course I'll do lifestyle counseling, but aggressive lipid management could be something to consider, with this population. So to me, that's, important to address, an important risk factor to address.
Yeah, absolutely. And I know I didn't really include a slide about that, but it's definitely a part of the conversation, that cardiovascular risk. I think if anything, for some of these individuals ends up being more significant than the dementia risk because like your patient, they may already have signs of it related to it. I don't necessarily repeat the testing if it's been done through some place like 23andMe. Well, I definitely have strong feelings about testing companies like that, and probably that's a whole nother talk in terms of that conversation. Generally for things like APOE, they do a pretty good job in terms of you can trust it. Can't ever say that with absolute certainty by any means, but I'm not a reason to necessarily go do it again.
Okay, thank you. And then one more question. So if we refer a patient to you or even with Invitae, like, is there genetic counseling available for out-of-state children?
So really kind of just depends on where you refer. individuals. So like some of the clinics within our region will see, depending on just where genetic counselors are licensed. For instance, I work with Genetic Support Foundation, and for instance, I'm licensed in all of the Pacific Northwest. So like I can see patients throughout the Pacific Northwest. Other members of my team are licensed in other states. So there are but we're not the only one. There are other telehealth companies too. And then depending on where people live, there may be centers of excellence that are close to them.
Okay, yeah, because if you have the affected adult who's positive, then of course the
Mhm.
children are going to want to pursue their own testing.
Absolutely. Yeah.
Okay, thank you.
Yeah, and you may have just answered Dr. Hammond's question about genetic testing available via telehealth, given the geographical limitations. So it really depends on the provider and where they're licensed. So it's like,
Mhm.
makes sense. Okay. Dr. Sussman.
Thank you so much for the great talk. Along with the in vitro testing, so especially for early onset when it seems to be spontaneous, most of the patients, as you said, they really want more information for their growing children if they choose to know once they reach, adulthood. With the in vitro panels, because they're not genome-wide studies, and with the few genes that we know, do you recommend sending them to counseling to do genome-wide more investigation if the invite, let's say, is negative?
It's a good question. So I think that it really depends on probably some of what the testing involved, and because there's different sizes of panels there too, and what's going on within the family history. If it's a family where it looks really suspicious in terms of, just who's affected and ages, if there's other things going on, then having more conversation about other testing, I think, is definitely warranted. I also, even if there isn't a plan to do other genetic testing, sometimes just having some of those follow-up conversations can sometimes be helpful for patients or families to just kind of understand where we're at in terms of research and our understanding of the genetics of this and what's going on within the clinical trial research realm of it.
And just one more. My understanding was even for early onset, still the minority is, having some inheritance pattern, of course, with variant penetrance. Would you remind us what those numbers are again for early onset? What % is likely to be inherited?
Yeah, so with early onset Alzheimer's disease, only, or I should say, for all of Alzheimer's disease, a few % are going to be due to one of these genes. Within early onset dementia, when we have truly familial early onset, a good proportion of them actually will have an identifiable change in one of those 3 genes, but it's not 100%. So it's not a guarantee for early onset that we're going to find.
Great, thank you.
I had a kind of a related question for you in terms of, I like the idea of genetic testing being helpful as we think about prognosis when it's positive. But, say you've got somebody who has all the hallmarks of BVFTD and all those genes are negative. What do you talk about? How do you talk about that?
Yeah, absolutely. It definitely comes up in terms of some families where I am almost certain we're going to get something back on it, and then it comes back negative. And really, it's that conversation of they're likely within that realm of the unknown, where there's still probably something genetic playing a role here, and we just don't know what it is or how to test for it. The other limitation with our testing is that the clinical testing through labs like Invitae, through Prevention, who do these panels, are good at identifying when it's one gene that's causing it. The testing's not good at identifying when we think there's multiple genetic factors playing a role. So it's possible that they're within the category where the testing's just not able to really look at it for them. I'm hopeful that we will get there in terms of being able to have a better test, but we're just not there yet.
Hi, Thank you for a really great talk. If you have a patient like middle-aged that both request for a genetic testing with he has both parents with diagnosed with dementia, Alzheimer, or maybe vascular dementia, maybe both, but both parents that are unrelated, I mean, they're not family related. Would you recommend testing?
So this is definitely, I would say my answer 10 years ago is different than how I approach it now. Primarily because a lot of the emerging therapies and clinical trials where, and the aspect of patients are so much more resourceful when it comes to some of this testing. If people want the testing, there are ways to figure it out and to get it, whether they go through a provider or not. And so as long as, so 10 years ago, I would definitely probably talked about this differently. And I'm like, nope, I'm not going to always order testing. I am much more willing to order the testing at this point. If they've met with me, had this conversation, understand the impact of it, and also understand that they're likely paying out of pocket for that testing, and it's not inexpensive to necessarily do. Because for a lot of those people, even though they know a negative result isn't certain, it still provides some level of relief for a lot of people to be able to say, okay, well, I've looked at what I can, I've done what I can through this process.
But they still have high risks because, you know, they have both, I mean, parents, even if they don't find it.
Yes, yeah,
Yeah, but
absolutely. And that's definitely a part of the conversation.
Mhm.
Any other questions, comments? Carol.
Yeah, thanks, Rachel. That was great. Just a quick question. I'm a primary care doc and geriatrician, and I will confess my ignorance. Did not know there was gene therapy available for FTD. Can you tell me, or anyone else on the call, tell me anything about that? Is that something we should be? Anyway, I just would like to know more.
There probably might be other people on this call that can speak to it maybe better than I can in terms of like the details of it, but there's absolutely, so the GRN gene does have approved therapy in terms of that type of FTD, and then there's a handful of other ones that are in clinical trials. I don't know offhand the different phases of the trials and stuff, but because of that, I'd have to look back, but I think that last year or the year before, some recommendations started to come out and be published that genetic testing should be considered for everyone with FTD because now that does not mean insurers are jumping on board and approving testing for everybody, but it's at least recommended to be considered because of some of the therapies that are coming out.
And can you just ballpark me? How many of the people with FTD have that gene that's susceptible to testing? Like 5%, 50%, 80%?
So I'd actually have to look and double check. I can definitely pull that up here. It's not the most common though. The
Okay.
C9 or 72 one is the most common in terms of the genetic causes. I don't know like a direct quote though for the percent, but I can definitely I have my little resources
know,
I always use with patients that I
thank
can
you.
definitely pull up though.
Thank you. I don't mean to
Yeah.
go
Yeah,
down
no.
that hole, but you know, just as we think about talking to patients about should we pursue further evaluation, this is obviously one of the reasons when we might.
Mhm.
Very good. Well, do you want to run through some of the vignettes you've prepared? That might
Yeah,
just
I
be
can
further
definitely do that.
conversation, discussion.
So I have just a handful of kind of different examples of cases of things that may come up with patients. We'll switch over here. There we go. There we go. So these are kind of just two different examples in terms of, I think, things that, you know, I definitely see a good number of referrals for in terms of ApoE. But kind of the two different sometimes ways it can come up where have an individual who does the DTC testing, they have a family history of Alzheimer's disease, and finds out that she does carry an E4 allele, so a higher risk variant. Or the ApoE, because of the cardiovascular piece, is often included on some of the different health and wellness panels, or some of the cardiovascular disease directed consumer testing. This gets included. And so having a patient who does this panel, trying to just do a healthy lifestyle sort of approach to their care, and finds out and is wanting to know what they can do to lower their risk for dementia. And so I probably could go on for a while in terms of different reasons people do this testing or find out about these results, but often then many of these patients, their next step is they go to primary care and say, I did this testing, I don't know what to do with this, where do I go? And I think that, you know, things to consider as a provider is kind of that recognition that most of the time these people are going to have done this testing and have not been given any information or good information before or after doing this testing. And so going back to that part of kind of just rebalancing that conversation for them and those risks of what this means. Like one of the early questions about like the cardiovascular piece, looking at kind of the whole picture for them. And those lifestyle factors are a huge part of things to talk about, because those are modifiable things that can be done. And sometimes that's so important for patients to be able to grasp onto something that they can do, an action that they can take as a part of this. And for any of these, I'm always going to say identifying resources, referring when needed is just a crucial part of the process for them. And then another kind of an example of a case is the FTD, the piece of it. So have a patient who's been diagnosed with FTD, and they don't know what's not. I see this quite often where a parent is estranged from the family, or they've passed away unexpectedly. We don't have much history. Definitely raises the question sometimes as to, was there some sort of behavioral neurological component there for why that happened? But then individual also has a family history of ALS, and those are just kind of immediate flags to say, okay, there might be something else that's going on here. And talking about in terms of who's making the decisions for the individual, has 4 children who are concerned about what that means for them. And sorry, my screen just trying to fix this here. There we go. And so definitely a high likelihood in a case like this. There's definitely the indication to consider genetic testing, but also balance of kind of who's pushing this and the reasoning behind it, and you know, determining those best interests for the individual and for the family. And in these situations, there's often a balance of the family dynamics, because not everyone's always going to be on the same page. And I've had cases before where multiple of the children have the decision-making, have power of attorney, and may want to, and are wanting to make different decisions within this for the individual. So kind of a continuation is that genetic testing is done, identifies a genetic cause, and you can and there's a split amongst the children as to what they want to do. 2 of them are wanting to do testing, they want to get it done immediately. one has no interest and one's uncertain. And the one that's uncertain has a history of significant mental health and concerns. And that really kind of goes back to the aspect of looking at all parts of this when having these conversations with individuals. Someone may come to you, let you know about this family history, that there is something genetic going on within the family. You may know about some of this history already for them. And so it's important to really have some of that conversation with them of, you know, where they're at in terms of their well-being and that balance for them. And not doing it in a paternalistic way where we're making the decisions for them by any means, but really helping support them through that process and weighing kind of all of the different factors for it. And then some of that kind of the aspects of considerations in terms of that people are going to have different preferences, the mental health concerns. Reproductive planning is definitely a big conversation that can happen for some of these individuals and families in terms of what decisions they're going to make. And then also insurance and employment aspects for them. Predictive testing, kind of duty to warn, which is, again, something I think we see in more than just this realm with healthcare. So a patient whose mother passed away from early onset dementia, he reports no health or memory concerns, but does let you know he was recently put on forced medical leave due to performance concerns. He expressed uncertainty about genetic testing, but after discussion opts to proceed. Genetic testing reveals a genetic variant that's causative for him, and he lets you know that doesn't want those results disclosed to anyone, doesn't want it to be shared with others in his life. And this happens it's not too uncommon for patients to really be nervous about having this information out there, and what people are going to do with that information. Some of the best that we can do is really, some of it is having those pre-test conversations, pre-counseling conversations, and really trying to emphasize the importance of that support system, the family dynamics, the impact that this can have for people. It still in the end is the patient's decision for some of this. We can't force some of it. We may not always agree with it, but we really have to be there and support them. We don't want to push them away and not have them follow with for long-term care as a part of that. And so sometimes it's a process in terms of working through that and getting them comfortable with kind of where they're at and coping with that diagnosis and the impact that it may have and what it means. Family, this is probably one of the other more common things that I see from a genetic counselor side, where have a patient who has concerns about her family history. Father developed Alzheimer's disease in his early 80s. Older sister recently was diagnosed at 76. She's worried she's next in line and wants to do genetic testing because she wants to know if she's going to develop dementia. Reports that she has no memory problems or cognitive concerns, so overall a healthy individual. And I would say this is more and more of the conversations I'm having, I think often really because of it being talked about in more mainstream media in recent years, with combination of trials, combination of I'm going to say the show wrong. I think it was Limitless with, I'm going to say the wrong Hemsworth, but one of the Hemsworth on one of the, and I bring that up because celebrity impact has a huge draw for patients. When that show came out, our organization saw a huge increase in people wanting to talk about this sort of thing. Kind of another example years back was with like Angelina Jolie and the BRCA genes, right? Like they have a huge impact in the conversation people are having when it comes from individuals like that. And so this comes back to one of the other questions where genetic testing is often not indicated in late onset cases. And this is where years ago, I would have been much harder about that aspect of saying, I'm not going to do testing. I am much more willing at this point to have that conversation. And if people are informed, they understand the limitations of it. I don't necessarily always want to be the barrier for it. And there are reasons to put a stop to, be that barrier depending on what's going on for an individual. But really our role is to be supportive and to help people through that process. And for many of them, often it's just that conversation. They don't in the end want to do the testing. They just want to be able to talk with somebody about this and understand what it means for them. And so they just need that space. And many people will say, you know what, I want to sit on this. I want to think about it. And sometimes they come back, sometimes it's 6 months later, they come back to me and say, you know what, I do want to do this sort of thing. But it's not uncommon for people to say, okay, I feel good about where we're at for it. And particularly if we can connect them with different resources or support groups to be able to talk through this more with other people who have lived it too. I think there are, so many references, and these are some of the more recent articles that I really have pulled from for a lot of this. So.
Outstanding, Rachel. Thank you so much. Great and familiar cases. And the other interesting thing is we see this in the research world too. I think about the all FTD study and families where the kids want to know the diagnosis and the parents do not, and so it's not just in clinical practice too. But Carol, yeah.
Yeah, and this is actually a follow-up to that. I saw on the case with I think it was case 3, the 48-year-old who had the positive test, and you had a bullet on there that said confidentiality / duty to warn, but I didn't hear you make a statement.
Yeah.
Are you saying he wishes to preserve confidentiality, and so that's what you do, right? Duty to warn doesn't supersede confidentiality.
Yeah, there are times, and I have been involved in cases because of someone's workplace in terms of what they've done, where we have had to get ethics involved and sort out some of those. So there are times where you do have to, because of other things in their life, consider, or there are sometimes aspects of like driver's licenses. That is a bigger conversation. I think that happens, and when to have those conversations and when it needs to happen with family too.
Great, thank you. But in that case,
yeah,
it was
in that case, it's kind of just that longer term follow-up and trying to really work through it with them and coping with the diagnosis and kind of hoping that eventually we can have that larger conversation for the family.
Thank you.
Any other last minute questions, comments? We've got a few more minutes. Other clinical experiences that resonate with you? Giving it the requisite 10 to 20 seconds of Zoom silence.
Oh, sorry. I just had a quick question. So if somebody wants to do the test and they're willing to pay out of pocket, so we do not start with gene sequencing. It seems that we need to start with one of the panels. Is there any specific panel for frontotemporal dementias, or it's just like an Alzheimer's panel that we send people?
Yeah, so
dementia panel?
it somewhat depends on the lab and how they've had it labeled for, which does make it a little bit difficult when you're trying to search for it. I use different labs for different reasons. So, and sometimes it is because of insurance, sometimes it's because of where other family members have had testing. But for instance, Prevention Genetics is really one of the only labs right now that has a broader dementia panel that includes all the different genes, and it actually does include ApoE on their panel, which many patients I meet with, that's something that they're looking for too, for it. And then they have smaller versions of it. There are a handful of labs that do the FTD specific panels. And then FTD is the one where there's also some sponsored testing. So through some of the pharmaceutical companies, because of the clinical trials, some of them are paying. Now you have to balance that in terms of the who's paying then for the testing, right? And who has access to that information. And so that's definitely a part of the conversation you have with the patient for it.
Yeah, this makes it a little bit complicated. And out of our knowledge, that's probably that's why we send patients to you.
Yeah, and that's definitely a big part of what I do in terms of sorting through that. I was just, before the call started, was mentioning that I saw a patient of Dr. Eisenberg's this morning for this exact indication, where a family history of early onset, and was really talking through the different options that we have in terms of the panels. And some of it is sometimes we'll put it back to individuals and the families and say, I'm going to send you a handful of the different options, look at them, and you tell me kind of what makes the most sense, because some people are like, I really just want the 3 genes. I don't want to look at anything else. While others are like, I really want to look at the broader panel for it.
Thank you.
Dr. Paris?
Yeah, I have a question. Thank you. What a great talk. I think we have to deal with this a lot, especially since the Helmsworth did the ApoE4, E4, and there's a lot to talk about. So I just, how do you feel about the Invitae LabCorp testing? Do you think they're pretty accurate?
Yeah, absolutely. I definitely use them. And the only reason I bring up like the prevention is that the Invitae one, they have a good FTD, they have a good Alzheimer's one. Their
Okay.
combined one also includes ALS genes with
Yeah,
it.
I wanted to ask too, because I heard from a neuromuscular specialist that the C9 ORF72 gene is like 100% chance of developing ALS. So how do you have that conversation? Like, do you also?
So it's definitely a part of the conversation, particularly for patients who have been diagnosed with FTD or a family, because it's not because no provider has brought it up, but sometimes it's just not, when they're getting these diagnoses, it's a lot, right? So they may not remember all of this information. And so sometimes it's kind of this oh my gosh, kind of moment for them when I'm like, we might identify that you're also going to develop, or other people in the family are going to develop this too. And so the Invitae panels are really good too. To be honest, a lot of I go between Invitae and Prevention for the testing. There are also a handful of other labs, particularly if I'm going to start looking at doing like an exome or genome, I may look at some of the other labs as a part of it. I don't always go that route, just because insurance is often not covering it. And I just don't want to stick patients with large bills if we don't have to.
Very much appreciate that. Outstanding. And we thank you again for such a wonderful talk, and just the wonderful service you provide to so many different patients in tough scenarios. We're lucky to have you. So with that, we will bring it to a close. I do want to let you know that on October 10th, our next session, we have a revisitation of the blood-based biomarker panel, given some changes and some developments. And that will be a panel of providers, including our own Dr. Gaster, who had to jump off, and a couple of our hub team members, and then Dr. Tom Grabowski, who is the director of the Memory and Brain Wellness Center here. So look forward to that on the 10th, and we will see you then. The CME information is in the chat if you are a UW person, and thank you, Kelly, for putting that reference in there too. We'll make sure we distribute that. All right, and with that, take good care of yourselves, and thank you again all for all you do.